Good morning, everyone. Excited to present this case today and this topic, all about abolishing the silo care mindset. And I want to kind of open up with the discussion. What do you feel is silo care? How would you define it? Go ahead.
It's when providers don't talk to each other.
Yeah. This is all about team collaboration, working together. Any other definitions?
Mark Pope, in the keynote he gave a few years ago, put a picture of silos up on the screen with no windows or doors, so nothing's coming in or out. They're just isolated locations.
I think this topic it's very timely. I have a very dramatic case that I'm going to present this morning, but it really represents a lot of cases and the complexities of the healthcare system and how we can all work together to really deliver exceptional care for these people. And there's a lot of barriers that we face as healthcare workers, but I want to talk about how we can abolish those barriers. In this case, we have a few providers here that are going to share their side of the story, but I really just want you to think about what it takes to work together, truly. We have so many things that are on our tables, in our practices, so many things that we have to juggle. And these cases are really important. And I have permission from the patient and from the family to be able to share this story and some pictures of this family as well. So just to kind of set the stage, this is back to my years of motocross. And as you can see by the arrow sign, as Dr. Edwards likes to point out, you can see a cast on my hand. I had pins in my hand, had a broken hand, and I was in a championship. And the reason I bring up these pictures is because this is my story of times that I received great care. I've broken over 30 bones. I've had 10 concussions. And I know a lot of you are like, that makes sense. But the reason I bring this up is I've had great care sometimes, and I've had sometimes not great care. And sometimes I feel like my team was working together, and sometimes I feel like they're working against each other. And that's just kind of my history that's really driven a lot of teamwork and really what I'm trying to create in our team and across healthcare as well, because we all have to work together for exceptional care. So to talk about that story, what are the barriers? Let's just kind of start out with this topic. What are the barriers that you face as a healthcare professional, as a clinician, that stop you from working with your colleagues? Go ahead.
EHRs come to mind, like initially, just everybody uses different systems and different, access points, and so that is already like a built-in communication barrier.
For sure, you can't just pull up the chart easily and just see their whole history.
I think you can,
Yeah.
It's my chart.
Be nice to have a universal
Yeah.
healthcare, charting system. Go ahead.
Say like health insurance, like knowing whether or not, health insurance is going to be accepted or what people do is going to be covered, and having that be kind of in the back of the mind, like I don't know if this is covered. So.
Yeah. I had a patient at Dr. Pitts the other day. He called me up and said, hey, I really want to see you to see this patient. And then all of a sudden we don't take her insurance. We ended up finding a solution for this patient so we could still see him, but yeah, that adds a huge complexity, right? All of a sudden you did your job to get them to the next provider, and then they don't take your insurance. It's huge. Any others?
I think it sounds just obvious, but we're all busy. And I got a message on Friday from a primary care doctor about a patient that he had in his office with a possible shunt malfunction. And I really didn't get an opportunity to answer his question on Monday, and by that point the patient had already been sent to the emergency room appropriately. And I'm trying to constantly respond, but it's tough, and I think sometimes it's not easy always to get back to people, but it can be time consuming.
Absolutely. I think it's probably one of the biggest things that we all face, right? We get to the end of our day, we're done, we're exhausted with all of our patients, and we got 3 voicemails of people we got to get back to. How do you carve out time for that? You call the neurologist, their day's over, right? It's Friday, you're not going to hear from them until Monday, And that just delays things. It makes things very complicated. Any other thoughts that you want to share?
I think just healthcare traditions. So everybody has a different way of practicing, everybody has a different opinion, and sometimes those get in the way of providing what is actually best for the patient, which might be just thinking outside the box just a little bit. But I think sometimes that's where that silo care comes in, is we're just like, no, we know what's right, and we don't think actually what is right for the patient.
Yeah, absolutely. I have a surgeon that I have not worked with before, and is in a locked out knee brace, post-op ACL. For the protocol says 6 weeks. This patient's ready to get out of this brace like today, and has the quad control, has all the criteria to remove the brace. But I call the clinic, no one calls me back for 3 weeks. What do? Right? I go meet with these people almost a month later, and they said, we never even got your message, right? So it adds a complexity. We could have sped that whole process up if we would have known. But now that I know that surgeon, I know that he's leaning on me to make that decision, which is great.
I think preconceived ideas or notions of what everyone does and what everyone's role is. We don't always understand how everybody actually fits together.
Absolutely.
We have an idea of what this person does, but we don't really understand, so we think, oh, they do or don't have a role in this case.
Absolutely. Therapists, physical therapists, what are the barriers that you face? There's a lot of PTs in the room.
I would say I see a ton of people that I talk to about direct access. They're like, oh, I don't have to go see my doctor to come see a physical therapist, and that's huge because they don't know that.
Yeah.
So.
Yeah. Any others? Go ahead.
Front desk issues.
Yeah.
With that communication again.
Maybe breakdown in communication.
But I think we all see that as a major problem.
Yeah, for sure. I think one of the things that, as I talked to Lindsay and Brandy the other day, is we have limited resources as therapists, right? To be able to make calls really quickly and to connect with providers. Like, I can't get someone a procedure overnight, but I know people that can. So think about these things as we move forward. So here are a few things that I just listed. Time, trust. We didn't talk about white coat, but like ego, pride.
White coat's not supposed to be.
Sorry. I don't see anyone wearing white coats anymore.
White coat ceremony, a whole other meeting.
Sorry, I don't mean that in a derogatory way. We talked about complexities of the healthcare system, just lack of care. I think this family that I am presenting on, one of the biggest things that they said is they felt that about 50% of people that they worked with didn't care. They just didn't care about them as a human. Communication breakdowns, priorities, right? We all have priorities. We get to the end of our day, we got our families to get to, inadequate resources. Those are all things. So I want to start out, kind of frame this. So I had a case that came into my office. We'll kind of break down this case, but we talked about this last week with Dr. Bowden. Did I pronounce that right? Dr. Bowden presented about mechanical low back pain. If 85% of these cases was mechanical low back pain, in my personal opinion, physical therapy should help them. 85% of them, right? And I personally feel that PT, we need to step it up. We got to get a lot more of these people better. And Dr. Bowden really presented that data last week. Are we really that good at treating people? We are the musculoskeletal, movement experts. We should be able to get mechanical pain better, in my opinion. And I've seen this in clinic. But about 15% of these, based on the literature, say that they're just random things that we need further intervention. That mechanical low back pain cannot help, right? It's really rare, 15% of these cases, but you see the breakdown here of different, even just like traumatic fractures, that's really low. Spondylolisthesis, right? Spinal instability, all these things are very, very low prevalence. And you can look at a ton of different research, and it's very skewed and very all over the place, but this just kind of gives a general summary of that. So mechanical back pain, really, if you look at Wolff's law, laws are irrefutable. So meaning you load things certain way, and this is actually specifically to bones. The bones will adapt based on the stress or demand you place upon them. This was supposed to be a picture that I forgot to put in, so. So this is the family. This is the gal that we treated. So this is actually one of my friends. He called me up on a Friday or on a Thursday night and said, hey, my wife has intense low back pain. Is there any way you can get her in? So we got her into the clinic. We started treating her. She's a 44-year-old female, presents PT acute low back pain. No red flags, like nothing. No, she had 10 out of 10 pain. Literally, this is handheld assist times 2. Like she's walking in like this to the clinic. And you can see this gal is a pretty young gal, very active, worked out every single day of her life, it seemed like. She'd been in 2 weeks of pain, progressively getting worse. She's sleeping the whole night through, right? There's no trauma, like her deep tendon reflex, no hard neurological findings, so appropriate for PT, right? Would you agree, therapists? Appropriate for PT. A lot of pain, but no hard neurological findings that we'd be extremely worried about. So we started PT. I'm going to simplify. This is not to break down PT today. This is simplifying. We got 5 sessions, right? So first session, mild improvement. I'm like, okay, we're on the right page, right? We're making a little bit of improvement. Session 2, minimal improvement. I'm like, all right, got to bring out all the bells and whistles here, right? Session 3, mild improvement with some heat, with some taping, kind of offloading her spine. Session 4, moderate improvement again. I'm like, okay, we're back on track. And then session 5, she came in and said, I was laughing with my friend last night. It was just a good time. We got together, and I was laughing hysterically, and now I have debilitating pain. What questions would you ask as a clinician? What comes to mind to you?
In terms of commonality, I've seen pretty severe disc herniations from smaller things, so that's one that comes to mind.
Yeah, sure. Any others?
Yeah, I want to know where, like, is pain just centralized? Does it go anywhere? Does it behave with any other things such as movement, is it down the legs?
No leg symptoms, but severe back pain or severe pain all the way from the cervical spine down to the sacrum. Go ahead.
And it sounds like possible Valsalva, so
Yeah.
increase the intrathecal pressure. So
Absolutely.
maybe disc.
Those are all great thoughts.
One comment is, you mentioned that a majority of patients, it would be like seeing colds in a family medicine office. The majority are fine, but there's some that are not. And based on this, you're thinking we need to escalate, we need to go and dig deeper or do some diagnostics, because this isn't the like you said, with mechanical run-of-the-mill back pain. For this kind of course, something's not normal.
Yeah, and I think a call to PTs. We got to make decisions faster. Like, I think a lot of our profession will keep seeing this patient and keep going and going. We're 20 visits in, right? Maybe not, right? But hopefully this case can really present the importance of escalating things when things don't seem right and they're not progressing in the way that we would anticipate. So what's next? What do we do? Maybe. There we go. Send her for an MRI, right? So you're a PT, you have limited resources, unstable fracture, diffuse metastatic disease, right? So there's all these things. I'll bring up her MRI here in a minute, but I call Reyes. Reyes gets them in for an MRI. Literally the next day, they did an exceptional job there. The doc calls me and says, your patient has cancer, has tumors all the way up and down her spine, all the way from the cervical spine down to the sacrum. She has 18 pathological fractures, rib fractures, and an unstable fracture at, I think it was T12, right? So as a PT, 4:30 p.m. at night, what do you do? Whenever we hear from our therapist, what do you do? What resources do you have? Where do you send this patient? Got to make decisions before 5 p.m.
I text Tyler.
Good move.
Yeah.
Smart move. I wasn't that smart. Any other things that you do? Where do you send this person? Oncology? How do you get to oncology? You just grab the phone, call up, look on the directory, and say, I need oncology.
Through the people you know.
Okay. Good thoughts.
The thing about that is I think the previous slide you mentioned, she wasn't having any nocturnal pain, and which really threw you off.
It really threw me for a
She
loop.
had some nocturnal pain, you'd be beginning to think some other things going on.
Absolutely. Does that work for PTs? Can you just call oncology? Would any PT do that? Probably not. Any other thoughts? Where would you send them? Wesley?
Well, if I have their GP, if they have a GP, I would call them and get them in the loop, so at least they're aware of the situation.
Great. This patient does not trust the healthcare system, did not have a general care. She actually came to us direct access. Makes it hard, right? You don't have anyone in her court. So is what I personally did. I'm not saying this is the answer, but 4:30 p.m. at night, I'm saying go to the emergency room. You have an unstable fracture. I'm worried about other things going down the road, right? It's Friday night. We got to get them to a doc. So I got the Edwards' favorite football team on here. So whose office should they be in? You know, so is what I did is I sent them to, this is the patient's perception of their care as they went to the emergency room. I failed to mention what to the patient what ER to go to. They went to Riverton ER because that was closest to home. They had 4 weeks of really poor care. They were sent home on meds with a back brace. Just figure it out. And they got a biopsy. They ended up, the biopsy was in error. It took 2 weeks to get the biopsy back. It was in error. They had to go back again. It was 2 weeks later. It was just a hot mess. And the team was not working together at all. And I just kept following up with them like, all right, what do you know? Like, there's no known plan. There's nothing that we know. He's like, I am exhausted. I've been in and out of emergency room 5 times with medication complications. She's been constipated. There's just been so many complexities. We don't even trust the healthcare system anymore, right? This is for almost 5 weeks. It's 6 weeks till she actually got the diagnosis. And then I decided, I'm like, man, we got to step back in. There's something that, what can I do as a physical therapist to speed this up? You know, because it's painful to watch. Because I believe in this team, this healthcare team. What can I do to speed this up? So I thought long and hard. And whose office should they be in? Who do you call? You call Brandy. So I got this football. This represents working together as a team. Brandy, you ready? So I called Brandy. What was our conversation, Brandy?
I said let's get her in as soon as possible. That's about all I remember.
Yeah. And what did you do? Got her in as soon as possible.
Got her in as soon as possible.
Okay, pass the ball to Lindsay. Lindsay took it from there.
All right. So luckily Brandy had, I think was with Dr. Edwards or something, so they looked at her imaging before she came to see me. So me and Brandy just quickly touched base before she came into our office. When she came to see us, she was in a wheelchair at this time. Like, you could tell this poor lady was defeated. Like, I don't even know that she really even looked at me, to be honest, at this point. Like, she just, I think, was so let down with the healthcare system in general. Dr. Edwards had looked at her scan, and with the cancer, they wanted to start chemo and radiation right away, which was the most important thing for her, as her care had been delayed so far. So as far as her T12 or her fracture, we just had her in a brace, and we're going to follow up with routine x-rays to see if it was healing appropriately. We couldn't, unfortunately, do anything to help with that at that time. But so we decided to send her. I felt bad for her because, you know, she's in all this pain. She's got so much delay in care so far. I wanted her to meet with one of our pain management doctors just to see if they could get her comfortable. I didn't know if kyphoplasty would even be an option, but I thought, well, it's worth sending you to someone that I trust, and then at least they can manage your pain. So we sent her to see Dr. Joyle at this point.
Yeah, you got that.
Oh boy.
It's all you.
BYU fan, so I can't catch
Here's
the
the scans, the MRI. I'm not going to break this down. This is not the purpose of our conversation. But Dr. Joy is going to talk about this in his portion of the story.
All right, so obviously we kind of know what the problem is. It's summarized here just a little bit more. Her main area of pain was kind of in the mid-thoracic area, mid to low thoracic area. So the question was, can we do a kyphoplasty to stabilize the fracture and give her some pain relief while she's getting the oncology portion settled? Treating patients with cancer, it's really important to get on top of those treatments because those can relieve, those appropriate treatments can relieve a lot of pain if they can attack it pretty aggressively. But she was struggling to get into oncology. I think she saw one oncologist, went through a round of treatment, didn't love the care, so she was in the middle of transferring to Huntsman. Fortunately, I trained at Huntsman. I know some people. I tried to facilitate that to see if they would want to tackle this quicker than I might be able to in the community, just because in a hospital setting, you got some other advantages working towards you, as opposed to in an office-based setting like where I work. We got to go through prior authorizations and things like that to make sure we don't put the patients in a tough financial situation as we try to render care to them. So we eventually talked about some spinal intervention to reduce the fracture, stabilize the fracture, and potentially even treat some of the tumor by doing intravertebral tumor ablation. She thought about that for a couple of weeks. She met with the oncology folks up at Huntsman, and they felt it was faster for us to help her, so we ended up taking her to the OR to do tumor ablation at 3 levels, which is what I'm limited to in an outpatient setting, and not get them in jeopardy with big hospital bills. So I've got a couple of slides here that just kind of show the instruments. This may be, okay, so we're looking at treatment options for the patient, chemotherapy, focused radiation therapy, surgery. There was some tumor invading the spinal canal, but fortunately she was still neurologically intact, so John obviously didn't feel like it was important to get in there and debulk those areas immediately anyway. And then we talked about the possibility of doing the vertebral augmentation and tumor ablation. All in while we're thinking about these other things and treating with somebody with this horrible cancer problem, the PTOT. We don't want her to get deconditioned any further. Spiritual counseling, emotional counseling, psychiatric management, and then pain medicine. So all of these things, they have non-siloed at University of Huntsman. They have a supportive oncology service that has components of these teams that meet together every week to discuss these challenging patients. And so they've got that unsiloed approach, whereas we in the community, we got to work through that a little bit more, So I did try to get her up there, but it just worked out that we were able to help her a little bit quicker. So these are the instruments we use. We can control the size of the lesion inside the vertebrae to make sure we get as much tumor treated and minimize potential neural injury. These are her intra-op images. So we did 3 tumor ablations and stabilized those levels with bone cement as well, so they don't decompress or don't fracture after the tumor starts to decay after the treatment. So she responded pretty well to this treatment. She came back within a week and was feeling much better in terms of her back pain, but unfortunately some of the other neurological issues from the spinal tumor started to manifest at that point. Came with a really bad radiculopathy, did not tolerate even a cc of epidural steroid fluid injection to help control that, so we abandoned that pretty early. So she was in rough shape by the time I was not able to help her anymore, and I don't know where she went after we made those attempts. I know she was in the ER a few times, so you have to carry the ball from here.
What I loved about what Lindsay said and what Dr. Joel said is, Lindsay said trust. Like, we have to have trust in each other, right? In order to trust each other, we have to know each other. Like, that's what this room is all about, right? Connection. And Dr. Joel said connections, right? He was connected to the University of Utah, and it allowed him to be able to make that connection really quick, right? This is just a quick slide on just revenues. This is complexity that adds to our system, right? And then I didn't check the facts on this. This is from a person that I trust. But you think about the amount of money that's passed through a healthcare system, and how much actually goes to. Only about 8% goes to the salaries of actual physicians, right? So that adds a huge complexity that allows us not to communicate because we're so stretched thin, right? So ultimately, what comes down to it, unfortunately I went to this patient's funeral this last week. I wanted to make this an emotional thing for a reason. This is a very dramatic case. A week before, there's a picture that I took. I went to lunch with my friend. This was only 2 weeks ago. And I went to lunch with him, and I asked him how his wife was doing. He said, not good. She hasn't been out of bed in 3 weeks. I said, you mind if we go see her? And this is not about boundaries, this conversation. This is my friend and his wife. So it took us about 3 hours to get her out, but we got her out in the sun 1 week before she passed away. And you can see her smile. But this was 5 months later. This is a family that no longer trusts the healthcare system. We did our part in the end. Unfortunately, after Dr. Joel, they actually went to Mexico and got treatment because they no longer trusted us, right? And this is a very dramatic case, but represents what patients go through just in a very short period of time. There's a 14-year-old and a 9-year-old that no longer has a mom. That was one of the hardest things to see in that funeral, is those 2 daughters that no longer have a mom. But what are we passing on? What are we doing for these patients? I want to highlight Dr. Joel. He did something I've never seen a surgeon do before. This patient left an orthotic at his office, and the patient, he had given his cell phone number to the patient's husband, and the patient's husband texted him and said, "Hey, can you come drop that off at my office?" As a surgeon, what would you do? He literally drove down to my office and dropped that off on a Friday night so I could get that to him on Saturday morning. Like, do we care that much that we can take care of those patients and get out of the busyness of what we do to really take care of them? So I want to open up just the last few minutes here for discussion. What are the takeaways, the key takeaways that you get from this discussion? What comes to mind?
I think we know that in busy practice, a lot of what you're going to be doing is stuff that you can schedule out, or it's routine, or it's the bulk of a lot of what we do is seeing patients and consulting with them and counseling with them. I think building time into your schedule deliberately for this kind of stuff. We know there's a reason why we can get a patient right in, because we've deliberately set up our schedules in clinic to have urgent appointments. This patient should have been admitted to a hospital, 100%, because she needed an oncologist and a radiation oncologist and a surgeon and a couple of other providers all collaborating together urgently, and it is so hard to do that in the community. That's why Huntsman set up that way. I think that it's unfortunate she didn't end up in one of maybe 3 or so hospital settings in the state that would have been able to handle a case like this and done that. And so
She ended up at 4 different emergency rooms.
Yeah.
One is IMC, one is Utah Valley. I mean, these are all people that could have got to the resource,
yeah,
but we missed it.
disappointing Utah Valley, and usually they she should have just been admitted and done the biopsy and got the oncologist involved right off the bat. Huntsman does a good job, but they're overwhelmed. We had a patient with horrible metastatic renal cell cancer, and all of the care had been done at Huntsman, and he's at Utah Valley admitted, and we could have done surgery, but they couldn't take him, and because they're full, so there's some challenges there, because that model is a good model. People get good care that way, so they're of course full.
Yeah.
So there's some challenges to it.
With her case, I don't think the outcome would have been much different, to be honest, if she got into that, in terms of her death. She had really advanced disease, and it was literally everywhere. So even with the right chemotherapy agent and the right radiation, she probably wasn't going to survive very long, just because, she compensated really well with this horrible disease, probably because she was in really good health, and it just manifested really late. That being said, those other components, the emotional support, the spiritual support, the psychological support, had that been in place for them, I think in conjunction with the medical team, their perception of the system probably would have been a lot better, and they would have felt better cared for, and that's the real tragedy.
Yeah, absolutely. Go ahead.
The complexity on top of that is that, yeah, you have this family that doesn't trust the healthcare system, but everyone around them doesn't either.
Mm-hmm.
because they've seen what has happened to this lady. They've known, the neighbors know about the ER visits. They know all the things that went on with this.
Yeah.
So you have this now community around this family that is like, I'm gonna think twice next time when I go in and see a specialist, or I go in and see a doctor or a physical therapist or whoever, because all in the back of their mind is this lady that's like, she's not dead.
Yeah.
You know, and so, you know, agreeing with what John said, I mean, surprisingly enough, as a nurse that has been on the floor in situations like this, that she wasn't admitted. That was the first thought in my mind, was like, there's something going on, get her in the hospital. You know, and so there definitely was a breakdown of care. There was a breakdown of communication across the board, even before they got to you guys. You know, which is a sad thing, and it happens, unfortunately. But it's that silo of care around them. Now it's a community that doesn't trust the healthcare system. So what are we going to do to get back there?
Yeah, it's one person, and all of a sudden becomes 100 people, right? I just want to end with a few quotes from this family. I asked the husband, what would you pass on based on going through these experiences? He said, and this is advice for healthcare workers, don't get caught up in the complexity of healthcare that you forget how to treat us as patients. You can tell who really cares and who doesn't. And then please fight to make healthcare great. Do it for me and my family. I talked to this patient just this morning before I came in. Went to the gym with him yesterday, and these are the things that he said. So obviously this is a very dramatic case, right? I want to make that very clear. We don't deal with these every single day. We don't have to communicate at this extent with every single patient. It's a very small amount. And I just hope to instill that this morning as we work with patients, that we do it, and we do it with such care as if it's our own family. Thank you.